Yeah, thank you very much for the invitation to present here some insights in our project on intravenous thrombolysis in patients with ischemic stroke and recent direct oral anticoagulants intake, which is an international collaboration. We are speaking here on behalf of the DOAC IVT and TRISP collaboration. Here are my disclosures. As you all know, the benefit of novel oral anticoagulants came from the reduction in hemorrhagic stroke and not from the reduction in the rate of ischemic stroke. So ischemic stroke, despite oral anticoagulant, is still very frequent, and the rates are in the primary prevention cohorts up to 1.3% per year, and you can double these in the secondary prevention cohort. So this is something we very frequently face in our daily clinical practice. However, the current guideline recommendations are somehow contradictory, but the majority of them is stating that patients who are oral anticoagulated with thrombin inhibitors or direct factor Xa inhibitors and who have taken the last dose within the last 48 hours are excluded from a thrombolysis therapy, from a medical reperfusion therapy. So they are a little bit different. The Japanese are a little bit more liberal. They focus here on an INR of less than 1.7 to allow patients to be thrombolyzed, while the American Heart Association is stricter, and also the recent ESO guideline on intravenous thrombolysis for acute ischemic stroke was quite strict here, pulling here a stop sign in front of to perform a thrombolysis therapy in patients who have taken the last DOAC within the last 48 hours before stroke, if you have not specific coagulation tests available. So at the moment, the guidelines really pose a barrier, a stop sign in front of the most important medical reperfusion therapy, which is thrombolysis. So, but the main question we have to answer is IVT safe in acute ischemic stroke patients pre-treated with direct oral anticoagulants, or is it not? And there was a recent evidence coming from a retrospective cohort study, a very large study, huge study, from Get With The Guidelines stroke hospitals, and all patients received autoplays. They managed to include more than 2,000 patients with DOAC intake and a huge group of 160,000 patients not anticoagulated as a control group. And they found no increased risk of SICH, of symptomatic intracerebral hemorrhage, if you compare this cohort of patients with recent DOAC intake, no anticoagulation. And they also found no differences in safety outcomes, including mortality. However, if you look in the details, they included patients with DOAC intake within the last 7 days. And you have to look in a sub-cohort from the Aramis sub-study to find these patients which are really we are interested in, and which are covered by the guidelines. So those patients who have had an intake in the last 48 hours. And you can find here that only 25 of them had this, and they found that the SICH was 8%, but with a huge confidence interval from 1 to range to 26. And interestingly, those 8 patients who had a last dose in the last 0 to 24 hours before the stroke, there was no SICH noted. So at the moment, we have to conclude that we have to have considerable uncertainty regarding the safety of IVT in patients with recent DOAC intake, and whether specific selection approaches are preferable. Therefore, we performed an international multi-center retrospective cohort study, which was registered here in Prospero, which is investigator-initiated, and we had no commercial funding. We included patients with ischemic stroke on prior DOAC therapy, which confirmed last intake within the last 48 hours or unknown, who received IVT, and we compared them with patients without prior DOAC therapy who received IVT, and both were allowed to have a mechanical thrombectomy or not. And our main outcome is symptomatic intracerebral hemorrhage. Our secondary outcome is functional independency at 3 months. And we were able to compare different applied selection methods, DOAC level measurements prior to IVT, prior reversal treatment, or intravenous thrombolysis without DOAC level measurements, nor reversal treatment or inadvertent use of IVT. And here are our baseline characteristics. We were able to include more than 20,000 patients, 832 on DOAC pre-treatment and 90,618 controls. You can see here easily that we had major baseline differences between the group, between DOAC patients and the controls, something we had to control for in our models. And you can also see here that there was differences, for example, in the rate of patients who had concomitant antiplatelet therapy and in the rate of patients who had mechanical thrombectomy. You can see here that we were able to find 30% of our patients to have received a DOAC reversal before intravenous thrombolysis. 27% were selected on DOAC levels, but 43%, 355 patients had no reversal or DOAC level check before thrombolysis therapy. And here's our primary outcome. These are the unadjusted SICH rates. Overall, we had 4.5% of the patients suffering from SICH. And in the DOAC group, it was 2.5% with an upper confidence interval of 3.8%. And in the control group, we had a rate of 4.5% and an upper confidence interval of 4.8%. And after adjustment for stroke severity and other baseline symptomatic ICH predictors, patients who received IVT and DOACs had lower odds of developing SICH with an adjusted odds ratio of 0.49 and a p-value of 0.005. We also looked on different selection methods. Here we lost some patients due to missing values. These are the original data without multiple imputations. And you can see here that the lowest point estimates are in the no DOAC level, no reversal selection group. And in the functional outcomes, if you look on the MRS 0 to 2, that means functional independency at 90 days dichotomized. There were no significant difference between the DOAC patients and the control group. We also had no differences when we returned to the pre-stroke MRS analysis. And we also had no difference in the association of DOAC therapy and mortality. Of course, this is an observational study design, which inherently has some important limitations. Of course, we have seen that we have important baseline differences between the DOAC group and controls. And we were surely not able to account for all residual biases. We expect some important selection bias in our cohort. And of course, we have used heterogeneous IVT doses because this was an international cohort. We also allowed for a 0.6 milligram per deciliter per kilogram body weight, IVT dose. For example, in the Asian populations, it was a minority of patients thrombolyzed with tenecteplase. But this is so far the last study addressing IVT in DOAC patients with confirmed last intake 48 hours or unknown. We did not find any evidence for harm for IVT in ischemic stroke patients with recent DOAC intake. And these findings were also consistent in different selection strategies. So we conclude that our results would support removal of recent DOAC treatment as a contraindication for IVT in acute ischemic stroke. And we have to thank all the contributors. We had contributions from more than 40 centers and 3 multi-center contributions. So thank you very much to all of them. Thank you very much.